Good morning, everyone. Hope you have a very nice dinner and they had a good rest last night. So I would like to thank Kyoto University to give me an opportunity to present a piece of our research finding. So first, I would like to acknowledge my research team member, Dr. Miron. Actually, she did her PhD with that project, so she's the one who carried out the whole research project. And then Prof. April, she is a colorectal cancer surgeon, and then also the co-supervisor of the PhD project. And then this study was supported by University of Malaya research funding. And then I would acknowledge our study participants who share very important information. And then also University Malaya Medical Center, they share all financial information with us. So I would like to give you a bit of study background, how global burden of colorectal cancer. Colorectal cancer is the third most common cancer worldwide. And then it is fourth common cause of cancer deaths. It's due to colorectal cancer, which causes 694,000 deaths. And cancer burden worldwide indicates that colorectal cancer accounted for the second greatest share of global treatment expenditure. So let's look at Malaysia. Malaysia, it is also colorectal cancer is the second most common cancer for both male and female. The prognosis of the disease is excellent if detected at an early stage, but the majority of Malaysian patients presented at the late stages. The rationale of the study, in spite of evidence that colorectal cancer is one of the most costly cancer, but still not enough data on providers and patients' costs, the result of treatment costs and its consequences of patients and their families could provide a message to the policymakers about the cost, financial impact, and the benefits by the early detection and management of colorectal cancer and compared to late presentation. So this is study objective. Our general objective to estimate the cost of colorectal cancer management in the tertiary hospital in Malaysia in both patients and provider perspectives, and then identifying whether the colorectal cancer patients and their families are facing a financial hardship as a consequence of healthcare payment. So we have three components in our methodology. First components, we estimate the patient cost, and then second component, we estimate the provider cost. Third component, we assess the financial burden of the colorectal cancer patients and their family. So patient cost estimation, the study design was a prospective cost of illness study. We conducted the study in the University of Malaya Medical Center. It is a teaching hospital and then also the tertiary hospital in Malaysia. The study population newly diagnosed adult patients with a colorectal cancer. Our study data collection period is from March 2013 to February 2014. We do have a selection criteria. The inclusion criteria, adult of more than 18 years old with the diagnosis of colorectal cancer, Malaysian, because the payment for the hospital for Malaysian citizens and non-citizens are quite different. That's why we decided to include Malaysian citizens. And the willingness to participate in the study, and the exclusion criteria, presence of more than one malignancy, we did exclude from our study. We use a universal sampling approach. We collected data on all patients who diagnosed as a colorectal cancer within study period. We use a study instrument as a self-administered question. The way we collect the data, first we approach patients who fulfill our inclusion criteria, and then if they agree to participate, we ask them to answer our self-administered question, and then we provide them cost diary so that they can take notes, whatever cost they incur during the treatment process. And for 6 months and 12 months, we did a telephone interview to the patients. So we developed the questionnaire after reviewing some treatment cost questionnaire and the household questionnaire. And then we did both content and feasibility was done, and then we also pre-tested the questionnaire before data collection. Patient costs include direct out-of-pocket payment, medical-related, is a hospital stays, tests, and treatment. Non-medical items, we did also include travel and food costs, and the indirect cost, loss of productivity of the patients and caregivers. For provider costs, it was collected according to the clinical pathway of the colorectal cancer from surgery clinic, oncology daycare, surgical wards, operating theater. We use both top-down and activity-based approaches. So I think as you all know, the estimating costs, we did a lot of assumption. So we try to verify our data collection process and the costing estimation. So we do ask the external opinions. Prof. Mas, now we ask to review our costing process and then take her opinion. So I do appreciate Prof. Masna's contributions to this research, especially for the provider cost estimation. And then we do also ask the colorectal cancer surgeon to review our costing data. And lastly, to estimate financial burden, we assess the financial burden both in subjective way and objective way. Subjective measurement, the participants were asked about the degree of difficulty and then paying for the healthcare using 5 Likert score, very difficult to not difficult at all. Objective financial hardship, we calculate the household catastrophic health expenditure by the share of health expenditure in the non-food expenditure. So, and then we use 40% as a catastrophic cutoff point. The results, during our data collection period, there are altogether 148 patients diagnosed as a colorectal cancer in University of Malaya Medical Center. But according to inclusion-exclusion criteria and they're willing to participate, total 138 patients are recruited for the data collection. Slightly more male participants than female participants. And the majority of patients are Chinese ethnicity. This is also true for Malaysia. In Malaysia, there are 3 ethnicity, Malay, Indian, and Chinese. The colorectal cancer incidence is more in Chinese ethnicity. Median age of the respondents were 63 years old. So you can clearly see a lot of patients are diagnosed at the late stage, like 50% are in the stage 3 and then 24% are in the stage 4. So this is a 1-year colorectal cancer patient course. So you can see the, the patients belong to the late stages cost more expenditure than patient diagnosed in the stage 1 and 2. And the indirect cost was 8 to 21% of total patient cost. So this is 1-year total colorectal cancer cost in UMMC. We show both provider cost and then patient cost. So once we compare patient cost, stage 1 and stage 4, stage 4 has almost 30%, more than the patient cost. But once we look at the provider cost, so it's almost double cost for the late stages of the colorectal cancer. So let's move on financial burden. This is a passive financial burden. We can clearly see, because we did the two times data collection, so it's a different passive financial burden. And at the diagnostic stage, it's around 23% they feel very difficult to pay for the colorectal cancer treatment. And in 6 months, almost 36%, so they feel difficult and very difficult to pay for the colorectal cancer treatment. And then at 12 months, almost 40%, they say they feel difficulty for the payment. So again, this is a passive financial burden. So we group early stage and late stage, and then we compare. So it seems people who are in the late stage, they perceive more financial burden compared to the early stages for the diagnostic phases and then 6 months after diagnosis. But there is no significant difference. It seems there is a trend, but there is no significant difference. So this is out-of-pocket payment as a share of catastrophic, as a share of capacity to pay. So 40% and more is our cutoff point for the catastrophic health expenditure. So at diagnostic phase, 48% of people has a catastrophic health expenditure. And at 6 months, 52.9% has faced a catastrophic health expenditure. And then last 6 months, only 10% faced a catastrophic health expenditure. So this is again, So this is a factor associated with the catastrophic health expenditure. This is result from multivariate logistic regression. And for that multivariate logistic regression, we use a catastrophic health expenditure. We spread it, over the 1 year period. So finally, the catastrophic health expenditure, the percentage of the prevalence of catastrophic health expenditure is a 47.8%. So household head, the female household head, the patient belongs to female household head, they are more likely to face a catastrophic health expenditure. Patient undergoes surgery, also they have more likely to face catastrophic health expenditure. It's very clearly that, people who belongs to higher income quartile 3 and quartile 4 are protective to face a catastrophic health expenditure. So it is very consistent with the study findings all over the world. People who belongs to higher income quartile, they are very much, protective from the catastrophic health expenditure. So this is not according to our assumptions. We assume that people who has a private health insurance might be protected from the catastrophic health payments. But our finding is not according to our assumptions. We can find 2 reasons, why we have such kind of results. One reason you may remember that Professor Mill mentioned yesterday. So because in our data, we just asked whether you have a private insurance, yes or no. Sometimes yes or no cannot answer all questions. Maybe it is a matter of the benefit package, how much the private health insurance cover. And maybe another one reason, our sample size is not big enough to capture the small differences. So this is some parameter of healthcare financing in Malaysia. Actually, Prof. Masna has already presented yesterday. Actually, Malaysia healthcare financing is pretty well apart from the out-of-pocket expenditure. Out-of-pocket expenditure is stay under 40%. But according to last report, the Global Monitoring Report for Universal Health Coverage, the report recommended to reduce out-of-pocket payment to 15 to 20% of total healthcare expenditure. So yesterday, the Thailand experience, the Thailand managed to reduce out-of-pocket payments to reach 15%. So this is the incidence of catastrophic payments for Malaysia. It was published in 2007. So you can see the catastrophic health expenditure in Malaysia for the general populations or general treatment, it's 2%. This is the lowest among all Asian countries. And this is another recent report on universal health coverage, recently released in 2014. That also is mentioned out-of-pocket payment concentrated among the rich, predominantly used for purchase of private care, and then low population level incurring catastrophic health expenditure. It's only 1.44%. So it seems catastrophic health expenditure, prevalence of catastrophic health expenditure for general population in Malaysia is quite negligible. But however, the general catastrophic health expenditure, the general prevalence is a kind of average expenditure. It includes all illnesses, from cough and cold to cancer and then end-stage renal diseases. Once we look at only the particular group of population like colorectal cancer patients, we can see the considerable number of colorectal cancer patients perceive healthcare payment as difficult, and then around half of them, 47.8%, were experiencing catastrophic health expenditures. Once we conceptualized our study, we did a systematic review. So during that time, there was no published study on catastrophic health expenditure among cancer patients. So once we, throughout, we are carrying out the study, there are 3 published papers. The study in the Korea found out 39.8% of the cancer household experience a catastrophic health expenditure. But this is not for the specific cancer, it's all cancer. And then study conducted in Tehran, Iran. So it's also found out 67.9% experience catastrophic health expenditure. And there was a study in the 8 countries in the Southeast Asia, which include Malaysia, found that average prevalence of catastrophic health expenditure among households with a cancer patient across all 8 countries was 48%. So our study finding is quite comparable with other study who especially focus for the catastrophic health expenditure among cancer patients. So first I mentioned, actually our main intention was this study was just an exploratory study. We intend to expand our study to multi-center and then more study population. But finally we found out, that action study included 9,500 cancer patients in ASEAN countries. That's why we stopped our data collection, because we don't think it is right, to repeating the study what other people already done. So in terms of determinants of the catastrophic health expenditure, the action study which conducted in the 8 countries in Southeast Asia, they have a catastrophic health expenditure. People who belongs to low income category, they have a significant higher odds of financial catastrophe and death. And then those without insurance was also more likely to experience financial catastrophe. So, but once you look at the odd ratio, it's 1.05 to 1.52. So it seems health insurance might have protected a cancer patient from the catastrophic health expenditure, but effect size is very low. So you can also remember yesterday's study on community-based health insurance in Laos. We also cannot see that health insurance have a protection for the catastrophic health expenditure. I want to step a little bit, from health economics and then health policy. You may have a question why colorectal cancer patient diagnosed quite late in Malaysia. So this is an answer for that question. So we conducted the study in March 2011. In the rural populations in Malaysia, 38% had zero knowledge score for colorectal cancer warning signs and symptoms. People who are higher education and then people who are higher income group, they have a significant associated with a better score of both recall and recognition of the warning symptoms. So that shows the cancer health literacy in Malaysia is quite low. That's why the cancer patients are diagnosed in the late stages. This is another study. You can see that the whole study in the poster number 35. So this is attitude and belief about cancer in Malaysia. It also shows prevalence of the anticipated delay for the rectal bleeding was 11.3%. So that means it's a quite high people who have a colorectal cancer. They have anticipated delay in help seeking. So my conclusion, majority of colorectal cancer patients present late stage. The highest cost of both provider and patient was found in advanced stages. In spite of high subsidization in the government hospital for the costly and prolonged disease like cancer, the patients still pay a considerable amount for the treatment. On the other hand, colorectal cancer patients also perceive the healthcare payment as difficult, and that around half of them were experiencing catastrophic health expenditure. So there is a promising possibility that early detection of colorectal cancer will reduce the cost for both patient and provider perspectives, and then also financial burden. So our study provides stakeholders and policymakers with informative data that they can consider in the policy formulation in order to guarantee the highest level of social protection or financial protection for the adverse financial consequences of the cancer patient. The studies conducted in Malaysia highlighted the need to increase the level of population cancer literacy and to instill the right cancer message to the general population as part of cancer prevention and control strategy. Early diagnosis and management of colorectal cancer therefore not only affect disease prognosis and survival, but has implication for healthcare costs and efficiency. Okay, that's all my presentation.